So we're dealing with a 28-year-old male. This is an older patient of mine. I've actually worked with him a few times for a variety of different pain problems. He's a weightlifter. He's also a runner. He likes hockey. He's also a firefighter professionally. And on the side, he does tiling. So obviously a very fit and active person. And the other thing that's interesting for him is that his work is going to require fitness, right? And the other piece, and this is a little unfortunate given the injury they have, is that he has to be able to kneel. So if you're laying tile, you're doing kneeling for long periods of time. And after you have a meniscus tear, it's obviously pretty tough to kneel, right? So it's one of the things we had to focus on over the course of time. So he had a traumatic meniscus tear. You can tear your meniscus traumatically, or can it be more of a degenerative tear that occurs over the course of time? For him, it was all at once. So he was crawling in his job, firefighting, and he felt a pop with pain. He had swelling afterwards and had some limited range of motion. He actually did go and get some imaging. I was not the first person he ended up seeing. He saw a physician first, and then he ended up going to another physical therapy place first and came to us afterwards. And the imaging confirmed a medial, so inside of the joint, bucket handle tear. And I actually didn't know this initially. So when patient first came in, he told me he had a meniscus tear, and he didn't really know which type of tear it was, which is actually quite common. It's pretty common for folks not to know what the heck is going on, specifically within their joints or with whatever injury, right? So we're talking about the knee here, but oftentimes people won't know exactly what's going on with the imaging. So that's one of the things I pressed on the patient later, and we'll talk about why that's important to know in our decision-making process over the course of time, right? So what kind of stuff hurts? So for this patient, a lot of stuff hurt initially. And that was walking, standing, squatting, lunging, kneeling, bending, and straightening, right? So everything kind of hurt the knee. And I'll tell you what, this is really depressing for a very active person because it's going to affect everything in their life. So not just their training, which is something that is typically something that people do to get rid of stress in their life, right? To add value to their life. And you're taking away that coping strategy, right? And the other part is that it's going to interfere with his ability to work well. And that stinks because pretty much everything in his life is affected at this point. His lifestyle, his work, his training. So suffice to say, he's very depressed at this point. So what about this patient do I know and I'm getting from the subjective evaluation that I think is important for his future progression from a physical therapy perspective? So for one, he's a very motivated person. I've worked with this person in the past, so I kind of know this firsthand. So he's going to be very compliant. Like I said before, I've worked with him with past injuries, and he's done a great job of just following through on everything that I've told him to do. Okay. The other thing that's kind of nice about this is that rehab for him is very, very high priority, right? So he actually had to stop doing his part-time tiling work on the side because he simply can't kneel whatsoever. And he's definitely struggling with his job as a firefighter. All right, excuse me. And here's the thing. So his sense of self-worth is wrapped up in his career as a firefighter, as it should be. I think it's great that people care about their career, right? And he's doing something that's obviously adding to my life, right? So if I have a fire, I want him busting through the door. I want him to be able to save me, right? And that requires a meniscus that works well. Also, he has to be able to exercise for part of his career, and he loves to exercise too. So a major injury like this really sets someone back psychologically because it's a major knock on their sense of self-worth, right? So because of this, the priority is pretty high to get out of pain and back to exercise and back to his job, right? So the other thing that was important about this patient is that he actually went to another physical therapist for a few months prior to seeing me, right? And oftentimes this happens just because we're out-of-network providers. We're a little bit more expensive, right? So because of that, early stage PT is sometimes handled by other people, right? And in this early stage PT, they just worked on the basics as they should. So restoring range of motion, working on swelling, getting that quad back a little bit. But the patient just didn't feel like they were making that much progress. They also didn't feel like the physical therapist really understood what the patient was trying to get back to. And it was one of those typical stories where you're going to a sports medicine clinic. I'm using quotations here because they call themselves, a lot of these clinics will call themselves a sports medicine clinic, but 80% of their clientele is geriatric. So if you get a young, fit person that's going to physical therapy at one of these clinics, they just don't feel like they, are supposed to be there. If you come to a clinic like ours, especially if you're an older individual, you might actually feel like you're in the wrong place too, just because we see so many young adults, so many young athletes. So when someone comes to a clinic like ours, it's the opposite experience, right? So that was one of the major reasons why they wanted to come see me. And the other piece is that they just wanted a boost. They knew that I was going to kick their butt and I would understand what they're trying to get back to. So they wanted that next step, right? So what were the goals that the patient have? And also what were the goals that I had, right, for that patient? I love to ask my patients, every single one of them, what are their goals? So we make sure that we're moving in the right direction over the course of time, right? So A, he wanted to prepare for surgery. And we'll talk about this a little bit later. But when he saw his physician, the physician did recommend surgery because it was a meniscus tear that could be repaired, right? Also, the patient wanted to be normal at work. He wants to be able to do his job responsibilities, get on with life, right? He wants to also make sure he doesn't hurt with all of his basic daily life, right? I mean, he's a tough guy. He's one of those folks that copes fairly well, but it hurts every time he tries to stand up. It hurts to straighten out his leg. He can't stand for prolonged periods or walk. Life is really limited right now. And last piece, and this is a little far off at this point, but it's always something that's on the top of my mind because I often feel that if we can get people back to some of the things they love doing, so like running, weight training, going to the gym, right? Then that's a major win psychologically and also from a physical therapy perspective for a patient. So he wanted to get back to hockey, running, and weight training, right? But that was kind of far off in his mind. He felt like, wow, that's, if I can get back to feeling better, that's a major win. But long term, I'd love to be able to get back to things I love doing. And then in my mind, I'm like, let's get back to these as soon as we possibly can while respecting that meniscus injury, because that's going to be a major psychological win. So done with the subjective portion. Next part of the evaluation is objective. What are we finding from an objective standpoint? From a a strength perspective and manual muscle test perspective, he had pretty good strength in all areas besides knee extension, right? Now, I didn't check this. We do objectively measure strength later on in the evaluation. I didn't do it today. I just figured that it felt weak, probably was weak. I wasn't going to gain anything extra by getting an objective measurement with a handheld dynamometer at this point, right? Although that's probably something that would be smart to do if I had the extra time, right? In terms of range of motion, so always want to check the range of motion at the knee. That's going to rule in potential meniscus pathology, but B, it's also going to be one of those things that you want to check and make sure you're progressing over the course of time. So he had pain with end range flexion, very common with meniscus pathology. It was about 20% limited. He also had pain at end range extension, which is about 10% limited as well. Pain at end range extension is very important to note, and it's also very important to tackle early on because from a function standpoint, so think about standing, walking, all of those things are require end range extension, right? So if you're limited there, then a lot of stuff is going to be painful and limited within your life. And it's going to make you compensate a lot and end up with other problems at other joints, most likely, right? So another thing you want to look for with meniscus pathology is there any swelling present? And yes, there was. There is some minimal swelling above the kneecaps, some on the medial side of the joint, right? Over the course of time, patients said that this was actually getting better, right? Which is great. The other thing you'll often notice in knee injury patients, especially those with swelling or after some sort of traumatic injury, is that they have a deficit in their ability to make a quad muscle. So basically, I'm just having the patient lay on their back, straighten their leg, go ahead and try to make a nice strong quad muscle on both sides. I poke around on the quad and I just get an idea of how well they're able to make that quad fire. Now, his quad wasn't too bad. And some folks, their quads feel like a bowl of mashed potatoes, right? It's terrible. You'll definitely feel this after a lot of knee surgeries as well. His wasn't too bad. I would say he had a minimal quad contraction deficit. That was probably worse in the weeks before this, though. From a regional interdependence standpoint, so we check the joints above and below to see if there's anything that may be relevant for their physical therapy rehab or injury prevention in the future. He's generally pretty mobile. So he's got decent ankle mobility. When he goes into a squat, normally he can hit full range, no problem. Great ankle dorsiflexion. If we look upstream at the hip, he's a little bit limited in hip internal rotation. This may or may not be something that affects his rehab over the course of time. We actually didn't address it too much because he was able to get back to most of his activities without trying to focus on hip rotation too much. But maybe for your athletes, if they're trying to get back to some sort of rotation, that would be a major, major consideration. What else do we see from an objective perspective? So for one, I just eyeballed this, but you can very easily take measurements. He had some muscle loss, looks like in the quad. I would say it was minimal at this point. So it wasn't a ton, but it's been 2 months since his injury. So you can kind of guess that that muscle would be a bit weaker if A, he can't make it fire, and B, it hurts to do anything. You'll notice that muscle will get smaller over the course of time. I like to check a straight leg raise as well. So have the patient lay on their back, keep the leg as straight as possible, flex the quad, and lift the leg up, right? What we're looking for is whether or not there's a quad leg, right? So if I start to lift up and my knee immediately starts to bend, that's known as a quad leg. I like to note how much they have. He started with a 10-degree quad leg. Great. We want to try to make that better over the course of time. From a gait perspective, when you watched him walk, what were we noticing? So A, we're just picking up immediately on that limitation with knee extension. So when he takes a step, he does not straighten his leg out before heel strike. You see that knee bending, and you also see the knee staying bent during stance phase. So when he takes a step, he actually looks a little bit shorter on that painful side, right? When I ask him to squat, what do we find? So A, he has limited depth. It really just hurts to load up the squat. The deeper you go, the more it hurts, right? And the other part is that you notice a pretty severe initially weight shift. Now, we actually have force plates. We use VALD, V-A-L-D, force plates to look at someone's squat. We can get some feedback about how much weight they put on their left leg versus the right leg. He was definitely limited to begin with. We noticed the same with his lunge. The lunge was painful, right? So pain is going to change the way you move, obviously. He shifted towards his non-involved side, right? And the other thing that was going on with this individual is that they were starting to get some patellofemoral symptoms, so some knee pain on the opposite side leg. This is probably because of all the compensation over the course of time, right? So he was banged up, he was hurting, and he was depressed, right? We did a step down test next. And what you noticed that he just really used a big hip strategy. So when he stood on one leg and tapped his heel like he's going down the stairs, he just had a ton of hip drop. He just didn't want to move through that knee. Obviously, the knee is painful. The quad is getting weaker. He probably doesn't want to move through the knee joint. He's moving more through the hip joint. All right. So he didn't want to translate the knee anteriorly when he did a step down task. We also noticed this throughout the course of his rehab. He just didn't want to bring the knee forward and use that knee too much. So that was a major thing we wanted to focus on in the future from a rehab perspective. So like I said previously, we actually had imaging available. I didn't have access to this imaging initially. So the patient went to the physician and they got some imaging, but they didn't bring it to me, right? So this is not the end of the world. I can start the physical therapy process, but I really wanted to know what the imaging was showing. Okay. We knew there was a meniscus tear. We didn't know what type it was initially. It ended up being a bucket handle tear on the medial side of the joint. What's nice about these types of tears is that depending on where they are, you can usually repair them, right? We'll talk about the clinical reasoning, right, and the decision making a little bit later about why this is relevant. Okay. But when I palpated the joint, so on the medial side, there was some tenderness to palpation. So I'm already thinking like this is probably a medial sided tear if I had to guess. They're going to be a little more common for reparable tears anyway. And that's what the doc is saying is going on right now. So did the patient have any mechanical symptoms? After a meniscus tear, it's pretty common to experience some clicking, some popping, sometimes some locking. And the idea is that that meniscus can get torn, get caught in the joint and create those symptoms, right? So he did have some clicking and popping. He didn't have his knee objectively locking. So objectively locking just means that when you try to straighten or bend, it gets caught or stuck and you can't go any further, right? So he didn't have this initially, all right? And then from a special test perspective, he had pain with end range flexion and extension, which helps to rule in some meniscus pathology. He had a positive McMurray's and a positive bounce home test, okay? So I like to use the meniscus composite score. I'll give you the link in the show notes to this. This is part of our clinical practice guidelines from 2018, I believe, in JOSPT. So he had a history of catching and locking, right? Or excuse me, not locking, but catching and popping. He had pain with forced hyperextension, pain with maximal passive knee flexion, joint line tenderness, and he also had pain or audible clicking with McMurray's maneuver. So that's a 99% specificity for ruling in meniscus pathology. Plus, we also had the imaging. All signs point to a medial traumatic meniscus tear, right? This ended up being a bucket handle tear with the imaging that we got. So here's what I want you to do next, guys. If you enjoyed this video so far, I have an entire course. It's free. It's called the Fitness Pain Free Mini Course. And we go over 3 lessons going to help you take a lot of this information that we went over so far and put it into practice. The first lecture is called Why We Need a Better System. So first and foremost, the way we treat fitness individuals, all right, athletic people in the gym from a physical therapy perspective is pretty much broke, okay? So we need a better system to serve the folks that are in the gym that get hurt, they want to get back to training, all right? Lecture number 2 is called 7 Reasons Why People Get Hurt in the Gym. And essentially, we have to know the reasons why people get hurt in the gym so we can keep them safe in the future, right? And when they get hurt, we have to know why and how to get them back to training in the gym. Okay, so a thorough understanding of this is very, very important. I actually have a really cool infographic that goes along with this lecture that you get for free as well. And lastly, we go over a case study of how to get someone out of pain and back to training. So these principles are all phenomenal, but we don't actually put it together and you don't understand how to create a program to get people back in the gym and keep them safe for the long term, then we lose, right? So I'll put a link in the show notes for this. It's a Fitness Pain Free Mini Course. Definitely check this out.